Under the leadership of Curtis Barnett, Arkansas Blue Cross Blue Shield's president and CEO, Arkansas Blue Cross is leading a comprehensive approach to address the opioid epidemic and respond to the COVID-19 pandemic and the needs of their members and their communities. Through the Together Arkansas Opioid Response Initiative, Arkansas Blue Cross is partnering with other state leaders to provide employers with resources to help them prepare, prevent, and respond to the opioid crisis. Arkansas Blue Cross has also expanded access to behavioral health and substance use treatment during COVID-19. To hear more about these efforts, we're now joined by Dr. Herbert Price, Arkansas Blue Cross Blue Shield's Corporate Medical Director. Herbert?
Thank you, Catherine, and thanks to Gary and Carlos. I'm going to be talking about how addressing opioid use disorder treatment in Arkansas during COVID-19. Arkansas is a rural agricultural state with some areas of high poverty along the Delta counties along the Mississippi River and with some booming areas. Population is a little over 3 million people, and we have a high rate of opiate use disorder in the state. In fact, in 2016, we were number 2 in the country in terms of prescribed opiates. We had a rate of 93.5 per 100 compared to the U.S. rate of 51.4. The state's number 1 in rice production, we're number 1 in duck hunting licenses, and we're number 2 in per capita gun ownership after Alaska. Now, in a state like that, it's remarkable that we're one of the few southern states that expanded Medicaid. And for people that were 120%, up to 120% over the federal poverty level, we got a waiver from CMS, and we bought them commercial medical policies. And initially it was called the private option, and now it's called Arkansas Works. So our members, our increase in members, all had commercial insurance. In terms of the number of overdose deaths in Arkansas, it's been trending upward. We haven't quite had the fentanyl crisis that some other states have had, although it is in the state. So we had, in 2018, 208 opiate overdoses compared to 400 of other drug overdoses. Now, our Governor Asa Hutchinson, he is a former DEA administrator in the first Bush administration. And when he was running the DEA, he called attention to the emerging methamphetamine threat in rural America. And he lobbied for prevention and treatment and drug courts when he was in that position. And he's doing really well as a governor. He respects science and medical experts. And he's done a good job during the COVID-19 crisis with his daily briefings. Other state efforts, he created a position for an Arkansas drug director, and it's like our drug czar. Director Kirk Lane came from a law enforcement background. He was a 35-year veteran of law enforcement, and he oversees in his position both enforcement efforts and treatment efforts in the states. And he has a strong emphasis on reducing stigma and on enabling and training peer counselors. In fact, his director, Mr. Jimmy McGill, is the DHS, Department of Human Services Recovery Coordinator, and he's in personal recovery himself. And in fact, back in the day, Director Lane had repeatedly arrested him for drug offenses prior to him getting into recovery. So there's a nice emphasis here in the state with the state government, on working with the recovering community and respecting people who are in recovery. Other efforts by the state, we've increased our prescription drug monitoring program, and we expanded Drug Take-Back Day. And in fact, last year we took back 26,000 pounds of pills compared to 7,000 pounds in neighboring states. We also passed a Good Samaritan law, which if you're in the presence of someone who's overdosing and you call 911 or you give them naloxone or you take them in to seek medical attention, you have immunity from arrest or prosecution for controlled substance possession and paraphernalia offenses. And the motto for this is don't run, call 911. So if you call 911 or contact authorities if someone's overdosing, you will not be charged. We've also had an increased use of naloxone in the state by police and first responders. Many police and first responders carry naloxone kits, and in the last 15 months we've had 471 lives saved by naloxone. Catherine mentioned that Together Arkansas, which is a statewide collaboration working on opiates in the workplace, and it's a collaboration between the State Chamber of Commerce, the Associated Industries of Arkansas, the Arkansas Foundation for Medical Care, and Arkansas Blue Cross Blue Shield, with the goal of creating a drug-free workforce and reducing opiate dependence. And Catherine also mentioned our CEO, Curtis Barnett. He's really been focused on addressing the opiate epidemic and having the plan help with those efforts. He said, the opiate epidemic is one of the biggest threats to the foundation of business and our economy today. Providing Arkansas employees tools to address a problem as pervasive as opioid use disorder is critical. Helping employees break the bonds of addiction and get and stay healthy keeps them creative, innovative, and productive, and that makes Arkansas strong. Now, some of the initiatives we've had prior to the epidemic, the COVID-19 epidemic hitting, in terms of our quality of care programs, we have a planned substance abuse prevention coordinator, and we do outreach to prescribers, identifying our members that have multiple prescribers and multiple pharmacies use. We also do outreach to providers if our members are on combinations that are likely to produce overdose, and we have care management outreach to members who meet certain thresholds. In the realm of communication, we provide opiate utilization reporting to collaborative health initiative partners, which are some hospital systems and hospitals in the state that we partner with, and to other physician group partners. And we have educational efforts on the risks of opiate misuse and treatment options through employee, member, and provider publications. And we instituted quantity limits on opiates. We allow a limited amount of opiates prescribed at one time. We limit them to a 7-day fill for acute pain patients with a daily limit of 90 morphine milligram equivalents. And any quantities over that per day requires prior approval. The maximum dose we allow is 200 morphine milligram equivalents, and we require patients to use immediate release opioids first before moving on to extended release. We took away the prior approval from Suboxone, and there's no cost share for the member for naloxone or Narcan. In terms of the opiate trend reports, this is our commercial population. You see there's been a steady decrease in the commercial, for the commercial population in the amount per member per month prescribed. That's the commercial population. And this shows the exchange, which is the expanded Medicaid population. We've also shown a similar trend line in reducing the amounts of per member per month. In looking at medication-assisted treatment, in our commercial population, we have a improving trend in terms of people being prescribed buprenorphine, and it's more impressive with the exchange population. We've definitely tried to encourage medication-assisted treatment for opiate use disorder and tried to increase prescribing for that within the state. Now, the other things we've done grants for education. We gave a grant to the Psychiatric Research Institute at the University of Arkansas for Medical Sciences for prescriber education on opioid management and dependency reduction. And then we gave 1,390 naloxone kits to the state for first responders. We also support community organizations and the National Alliance on Mental Illness and recovery organizations that have foundations. Now, when the COVID-19 pandemic hit, we responded by, we stopped prior approval requirements. So for our inpatient, for substance use treatment and behavioral health, for residential treatment, for partial hospitalization and intensive outpatient, we got rid of prior approval. We stopped concurrent review. We request them to give us a pre-note notification so we can help with the member with case management after discharge, but there's no cost sharing for behavioral health or substance use disorder treatment. There are no co-pays, there are no deductibles, and no co-insurance. For the outpatient substance use treatment, and for the inpatient and partial and residential, we've had about a 12% decrease during the COVID-19 for people being admitted to behavioral health facilities and substance use disorder treatment facilities. We expanded outpatient substance use disorder treatment. Again, for that, we waived co-pays, co-insurance, and deductibles. We opened up some telephone codes that we had never covered before as a plan. In Arkansas, there was a restriction in that the state law was passed where provider state boards had to meet the level of stringency of the requirements of the state medical board. And a couple of the other provider boards had not done that quite yet. So our first move was to try to open up the telephone codes to allow providers to use the telephone. And then later the telemedicine codes were declared. A provider could use a telemedicine code and by using a telephone. So it was we got rid of the audio-visual requirement with the telemedicine technology. So we opened up telemedicine to substance use treatment disorder providers, the MDs, DOs, APRNs, psychologists, licensed psychological examiners, clinical social workers, and licensed professional counselors. For these are the telemedicine codes that were opened up they'd always been in existence, but we removed a lot of the requirements. So these are for the psychiatric diagnostic codes and psychotherapy codes with and without evaluation and management. And there was also a family psychotherapy code with the patient present or without the patient present that was covered by telemedicine. And for partial hospitalization and intensive outpatient programs, we cover the individual psychotherapy and family psychotherapy components of the program by telemedicine. Now this slide shows the office visits versus telehealth. So you see this is for both medical and for behavioral health treatments, including substance use disorder. You see there's been a decrease starting in March and April as the COVID-19 crisis kicks in, and then you see a decrease in office visits and an increase in telemedicine visits. This is for all services. This is looking at the same number in terms of total encounters. There's been a decrease in encounters, but there's been a marked increase in telemedicine services for both medical and for behavioral health treatment. These are the telephone codes that we opened up, and we haven't seen much uptake for the telephone codes. This is primarily because once telemedicine codes were declared to be, you could use a telephone to do them, and they pay better. People went to use a telemedicine instead of the telephone. And this shows the dramatic increase in telehealth visits for behavioral health and substance use disorder as the crisis kicks in February, March, and April. This is the telehealth percentage. This is looking at behavioral health services and what was telehealth and what was office visits. And you see it's now pretty much all done by telehealth here in the state. And this looks at opiate and stimulant use disorder by place of service. And notice there's an increase as we went to telemedicine in services provided to opiate and stimulant use disorder. that was not there when it was primarily office-based visits. So this has increased access to this population during the COVID-19 crisis. And this slide compares office visits to telehealth visits for opiate and stimulant disorder, and see that again the increase in telehealth is pretty dramatic. Looking at opiate and stimulant disorder use by diagnosis class, this looks at the blue is opiate-related disorders, and the orange is other stimulant-related disorders. And more people there are more treatment encounters now with telemedicine and with the COVID-19 than there were previously. Looking at total services, percentage of total services, again, this shows the number of people that are opiate-related disorders in blue, and an increasing number of people, percentage-wise, are seeking treatment for stimulant disorders. The final thing I want to talk about is that there's been an explosion in virtual 12-step meetings in the recovering community. Alcoholics Anonymous, Narcotics Anonymous, Al-Anon, and adult children of alcoholic meetings have moved to Zoom. And people can go to multiple meetings multiple times a day in multiple states. In fact, in the AA community, there's a program where people try to do 50 states in 50 days. So you'll get people visiting from other states that are coming to Arkansas to get the A knocked off their list. Initially, there was a concern about Zoom bombing, where people would get into an AA meeting or a recovering meeting and disrupt it. That seems to have been controlled pretty well by passwords and by better management by the meeting chair. And for a meeting format where the chair calls on participants, it works really well. If you have a really large meeting, everyone needs to be on mute, and then the chair will call on people, and they'll unmute themselves and have a chance to share. And this has really been well received in the recovering community. How to find online meetings, basically just go to aa.org and click on your state and look for AA groups near you and click on their website, and that'll give you the Zoom number, the Zoom meeting number, and the password, both for open meetings and for closed meetings. And this works for both Alcoholics Anonymous and Narcotics Anonymous. So in conclusion, Arkansas Blue Cross Blue Shield efforts during the COVID-19 pandemic increased access to treatment for opiate use disorder and stimulant use disorder. Use of telemedicine for opiate use disorder and substance use disorder treatment has increased exponentially. This will probably continue after the pandemic. And recovery groups have successfully went online during the pandemic, and virtual AA and NA meetings will continue after the pandemic period ends. Thank you.